Okay, thank you for joining us. Today's webinar, which will be recorded and provided with captions along with the slide presentations from our panelists, is concerning HIV drug resistance. This is an opportunity for civil society, communities, academics, clinicians to get around a table, a virtual one, talk about some of the new data that has come out, and uh, figure out how this links with ongoing advocacy efforts that is meant to drive back and address the unnecessary suffering as well as needless death arising from disease progression among people living with HIV. So, to introduce myself, my name is Sharon Ann Lynch. I'm the co-director of the Center for Global Health Policy and Politics. The center is based at the O'Neill Institute for National and Global Health Law at Georgetown University. We work with a wonderful coalition of activists called the Fight AIDS Coalition. The Fight AIDS Coalition, or FAC, was formed in order to push back on those needless suffering, on this needless deaths, and also to raise the profile of the persistent trends in terms of mortality and morbidity. So just one fact before we dive in. Over the last 4 years, we have yet to go under annual deaths of 600,000 people each year. I don't think we talk about this enough. My colleagues in Fight AIDS Coalition don't think we talk about this enough, as well as what can be done to address it. So the Fight AIDS Coalition has been pushing for the missing medical tools and services to better detect, prevent, and treat advanced HIV and AIDS. Advanced HIV being when people progress to develop symptoms and signs of stage 3 and stage 4. So some of those common opportunistic infections. Or if their immunity has been weakened to a point where their CD4 count is 200 or below. Now that's for adults and adolescents. For children under the age of 5, for example, all children living with HIV under the age of 5 are considered to have advanced HIV because they are particularly at risk of severe disease and at risk of death as well. So, what is the link here with HIV drug resistance? Well, as people working on the ground at the global level, at the regional level, on pushing for greater access and quality of services, HIV drug resistance is a part of that. We're going to hear more in terms of the link between quality, HIV drug resistance, and as well, what is needed in that quality package of care to better address HIV drug resistance. So our first panelist is my colleague, Sanjana Mukherjee. Sanjana is a fellow with the Center for Global Health Policy and Politics. She is a microbiologist by training and has worked on issues including AMR, public health policy issues, and HIV. So AMR, you're going to tell us what that means. And it's also very topical because in New York City, the UN has been discussing this in the lead up to a high-level meeting. So Sanjana, over to you, please, to lay out the basics for us.
Thanks so much, Sharon Ann. I'm just going to share my screen. Great. Thank you, everybody, for joining. I agree with Sharon, and I think 2024 is a very important year for AMR, considering the high-level meeting that's coming up in September this year. And I think HIV drug resistance is such a timely topic to talk about this year and just understand what the problem is and discuss effective ways to address it. And so my goal for the next 5 to 7 minutes is really providing you all with a very brief introduction into what drug resistance is and how drug resistance develops. And so to understand drug resistance, it's important to understand the HIV life cycle. And so antiretroviral drugs, they target very specific stages of the life cycle. So the first stage is the binding stage, where HIV attaches itself to the CD4 cell, and ARVs such as the CCR5 antagonists, as well as post-attachment inhibitors, they block this step. Coming to the second step, which is the fusion stage. So in this stage, the HIV envelope basically merges or fuses with the CD4 cell envelope, and this allows HIV to enter the cell. And fusion inhibitors, they block this step. The reverse transcription stage is the next step. So this is a very important stage in the life cycle. This is where HIV RNA, it gets converted into HIV DNA using this reverse transcriptase enzyme, which is represented by this little green circle over here. And ARVs such as the NNRTIs, which is the non-nucleoside reverse transcriptase inhibitors, and the NRTIs, which is the nucleoside reverse transcriptase inhibitors, they basically target this stage of the life cycle. Then coming to the fourth step, which is integration, this is also an important stage in the HIV life cycle. This is where HIV DNA, represented by this little red line, it integrates into the human or CD4 cell DNA by this integrase enzyme represented by the blue circle. And this is where the ARVs called integrase strand transfer inhibitors, or INSTIs, they block this step in the life cycle. Next, the replication and the assembly stages. HIV basically begins to make more of its proteins, more of its RNA, and then moves to the surface of the CD4 cell to form what is called an immature HIV virus. And it's when during the budding stage where the protease enzyme, which is this little yellow circle in the cell, that basically helps in the formation of a mature virus particle. And protease inhibitors, they basically block this step. And so when drug resistance emerges and renders one of these ARVs ineffective, it's because one of these stages of the life cycle can continue to happen. So why does drug resistance develop in HIV? And the really simple answer is that HIV actually just makes a lot of mistakes when it replicates. The HIV reverse transcriptase enzyme, it makes a lot of errors when it converts RNA to DNA, and cannot correct these errors. So essentially, it lacks what is called proofreading activity. So these errors or mutations, they're basically changes in the genetic sequence of the virus. And some of these changes or mutations, they basically result in drug resistance. Mutations can result in different amino acids being encoded at a particular position in the new protein. And so let's look at an example called, which is the M184IV mutation. So this is a very common drug resistance mutation. It has been mentioned many times in the new WHO drug resistance report. So we'll be talking a little bit more about this in the coming slides. So M stands for the original amino acid. So in this case, it's methionine. At position 184, it is replaced by either I amino acid, which is isoleucine, or the V amino acid, valine. So once M is replaced by either I or V at position 184, that can result in drug resistance. So let's look at a scenario to see how drug resistance can be selected. So among a person who's living with HIV, who is currently not on antiretroviral therapy and is still in the pre-treatment stage, HIV replicates at a very, very high rate. So it produces billions and billions of virus particles daily. And like I mentioned in the previous slide, reverse transcriptase enzyme, it makes a lot of mistakes, right? And so when it does that, mutations arise, which are represented by these little stars in this figure. Once a person with HIV, once they start antiretroviral therapy with good adherence, they maintain suppressed levels of the virus, and HIV replication remains insufficient for these mutations to occur at higher frequencies. However, with inadequate adherence, those viral strains which have these mutations, they basically get selected in the presence of the antiretroviral drug and eventually become dominant. So earlier this year in February, WHO released a report which summarizes recent information on HIV drug resistance, especially to INSTI drugs. Dolutegravir is an important example of an INSTI drug. So WHO recommends HIV drug resistance monitoring and surveillance as part of both the ART and PrEP programs, and also recommends genotyping. Genotyping is defined by generating HIV sequence data of reverse transcriptase gene, the protease region, as well as the integrase region. And one of the major findings from this report was that while drug resistance to DTG, dolutegravir, in clinical trials is low, so less than 3%, however, some observational data from cross-sectional studies done in 4 LMICs, so Malawi, Mozambique, Uganda, and Ukraine, they actually found prevalence of DTG resistance ranged between 3.9% to 19.6%. And so the important point here is that the levels of DTG resistance that is observed in real-world populations receiving antiretroviral therapy, it's appearing to be higher than that in clinical trials. And so some of these results basically show the importance of resistance surveillance and monitoring, especially at the national level as well. And so because WHO recommends genotyping the reverse transcriptase and integrase regions, I'm going to spend a little bit more time just talking about how resistance develops in these cases and what are the mechanisms of drug resistance here. So in the case of NRTI drugs, they block the reverse transcription stage of the life cycle. And how they do this is they basically get incorporated into the growing HIV DNA strand. So this is how they block the life cycle. When drug resistance happens, it's because there are mutations in the reverse transcriptase enzyme that prevents the incorporation of NRTI drugs into the HIV DNA strand. So this can happen via 2 ways. One is that there's decreased incorporation of the drug into the DNA strand. And the second way is that it actually just gets removed or excised from the HIV DNA strand. And so the examples of some of these mutations involved in this type of resistance is the M184IV mutation, which we talked about before, as well as the K65R mutation. And these mutations have also been associated with PrEP resistance. This information was also in the WHO HIV drug resistance report. So coming to NNRTIs, NNRTIs, they also block the reverse transcription step. So how they block reverse transcription is by actually binding to a pocket of the HIV or reverse transcriptase enzyme. And so drug resistance happens when there are some mutations in the pocket of the reverse transcriptase enzyme that alters this pocket so that NNRTIs cannot directly bind to it. So a really simple way of thinking about this is a lock and a key. So, you need a very specific key to fit a very specific lock. And if there's some sort of change in either the lock and key, it doesn't fit well, right? And so that's the same principle behind how these mutations change the binding site of the enzyme in such a way that the drug can no longer bind to it. And so an example of such a mutation is the K103N mutation. And then coming to INSTIs, INSTIs such as dolutegravir, they block the integration step, and they do so by binding to the HIV integrase active site. And so mutations occur when there are mutations in the integrase enzyme that prevents INSTIs from binding to the enzyme active site. And this, again, is the same principle that you can think about as the lock and key mechanism. An example of mutation is 263K mutation. And another point that I do want to mention about dolutegravir is that it has something that's called a high genetic barrier. And you may come across this term a lot. And what that basically means is that multiple mutations are required in the integrase enzyme to have some sort of impact on dolutegravir. And so just quickly summarizing everything so far, ART drugs, they target different stages of the HIV life cycle. And drug resistance is a natural phenomena where HIV has certain mutations that can render the ART drugs ineffective. And so when this happens, HIV can continue to replicate and treatment will fail. One of the factors that has been associated with drug resistance is ART non-adherence. And then a combination of ART drugs, they can reduce the likelihood of the virus developing resistance. And then lastly, we need either single mutations or multiple mutations that can result in drug resistance. And with that, I'm going to hand it back to Sharon Ann and hear from our other speakers.
Sanjana, thank you so much. And I'd like to ask everyone, if you have questions, please feel free to write them into the Q&A box. We have ample time in this webinar. We have learned from our previous webinars on AHD to make more time for questions and answers, and also to hear from you all, so that this is not just a one-way conversation. Now, over to our next guest. We are fortunate to have the global expert on HIV drug resistance with us. So Michael Jordan, Dr. Michael Jordan, is the co-chair of the HIV-DR, that's HIV drug resistance, surveillance and monitoring working group for WHO. In addition to being a consultant and expert to WHO, Michael is also the associate professor of medicine at Tufts University in the US and has been leading this work for quite a while. Michael, thank you so much for making yourself available, joining, and for your work on this incredibly important issue. So over to you, Michael.
Thank you very much, Sharon Ann. It's a privilege to be here. Good morning and good afternoon. Hopefully you should see my screen. So good morning. It's a privilege to present to you an overview.
Michael, I'm so sorry to interrupt. We see the notes and everything, not just the presenter slides.
How is that?
Ah, perfect. Thank you so much.
So thank you. Good morning and good afternoon. It's my privilege to present to you an update of HIV drug resistance during the era of dolutegravir-based antiretroviral therapy. I have no disclosures or conflicts of interest. As of July 2023, 116 countries had adopted dolutegravir as part of preferred first-line treatment for adults and adolescents. This represents a 93% increase from 2020. Indeed, the introduction of dolutegravir-based therapy has been a game changer, both with respect to population-level viral load suppression, often well in excess of 90 or even 95%, but also with respect to the prevention of HIV drug resistance due to dolutegravir's high genetic barrier to the selection of resistance, as we heard in Sanjana's presentation. Indeed, achieving such high levels of population and individual viral load suppression indeed is, or is the equivalent of, HIV drug resistance prevention. As we heard in the first presentation, HIV drug resistance is caused by mutations in the HIV genome that affect the ability of antiretroviral drugs to block replication. HIV drug resistance does matter because it can compromise the effectiveness of ARV drugs in reducing incident HIV infection, and also can be associated with associated morbidity and mortality. Broadly speaking, and for the purposes of my presentation, there are three categories of HIV drug resistance. The first, acquired HIV drug resistance, so that will be drug resistance in people receiving antiretroviral therapy with detectable viral load. Transmitted drug resistance, which is resistance in recently infected individuals, And finally, pretreatment resistance, which is detected in individuals initiating or reinitiating antiretroviral therapy. In the first part of my presentation on data, I will focus on acquired HIV drug resistance. We already heard a little bit from Sanjana about the data coming from a systematic review meta-analysis presented in the global report. In this slide, which I've taken from the global report, these data are also published in a peer-reviewed manuscript. I'm highlighting three scenarios, scenario 1, 3, and 4, in dark blue color, which have particular public health relevance. As I mentioned, these data all come from published clinical trials and present the results of a systematic review meta-analysis. In scenario 1, we're looking at antiretroviral drug-naive individuals infected with HIV who start dolutegravir and 2 NRTIs. In scenario number 3, we're looking at ART-experienced individuals with failure to suppress viral load while receiving an NNRTI-based regimen who were switched to dolutegravir and 2 NRTIs. And in scenario 4, we're looking at ART-experienced individuals with viral load suppression who were switched to dolutegravir and 2 NRTIs. What we can appreciate at the bottom is that the prevalence of dolutegravir resistance in individuals failing to achieve viral suppression is overall extremely low. In scenarios 1 and 4, indeed, the prevalence was well less than 1%, and the prevalence in scenario 3 was around 1.6% by week 48 to 96. I juxtapose that with data coming from real-world surveys. In this slide, I'm sharing with you surveys implemented following US CDC and WHO guidelines, data from Uganda, Ukraine, Mozambique, and Malawi. If we focus first on Uganda, Ukraine, and Malawi, we see that the prevalence of DTG resistance in individuals in whom their regimen fails to achieve suppression ranges somewhere from around 4% to 8%. But we need to keep in mind and put this in perspective, because the prevalence of viral load suppression in individuals taking dolutegravir-based ART is extremely high. So the absolute number of individuals with acquired dolutegravir resistance is very, very low. In fact, in the NNRTI era, that's use of efavirenz and nevirapine-based therapy, we saw the prevalence of NNRTI resistance amongst individuals failing to achieve viral suppression ranging from 70 to 90%. So here we see far, far lower prevalence of resistance, really attesting to the fact of dolutegravir's high genetic barrier to the selection of resistance. Now, in Mozambique, what is important to realize is that the inclusion criteria of this survey, which was done following a clinic-based method, included only heavily treatment-experienced individuals who were transitioned to TLD and who experienced persistent virological failure prior to switch. So that group did have a higher level of DTG resistance, but overall relatively low compared to prior NNRTI era. In a couple of slides, we'll come back and unpack some of the determinants behind why we may be seeing some of these higher levels of resistance in people who are heavily treatment experienced. First, however, I'd like to call your attention to these data presented from the South African, these data from South Africa, rather, presented at the 30th International Workshop on HIV Drug Resistance and Treatment Strategies in September of last year, which compared drug resistance prevalence data obtained in 2021 and 2022. And these data really do underscore the importance of optimal adherence to ART. So in this study, ARV drug level testing was used as a proxy for ARV drug exposure. In 2022, only 62% of patients with viral load greater than 1,000 copies had laboratory confirmed ARV drug levels, indicating suboptimal adherence as the most frequent cause of detectable viral load. Among specimens with detectable dolutegravir levels, integrase inhibitor drug resistance was observed at a prevalence of 11.9% in 2022 compared to 0.2% in 2021. So again, one of the main messages here is that the majority of people in whom DTG-based ART is failing require enhanced adherence counseling. Failure is happening because of the need for optimal adherence. It also underscores, very importantly, that high-quality transdisciplinary research and indeed co-creation with community members is required to develop optimized evidence-based interventions to support adherence. In this publication from the IDEA cohort, we learned that resistance to NRTIs, perhaps heavily treatment-experienced individuals, thinking back to the Mozambique data, was a major risk factor for dolutegravir resistance, indicating that individuals receiving functional monotherapy may be more likely to develop dolutegravir resistance. And while resistance to NRTIs may not affect treatment failure risk, it still can increase the risk of acquiring resistance in cases of failure. So on the right-hand side at the bottom, you see that potential and low and intermediate high-level NRTI resistance increase the risk of acquiring drug resistance in cases of failure with an odds ratio of 5.23 and 13.44, respectively. I'll focus the next few slides on pretreatment drug resistance. This first slide is really sort of proof of concept. Haiti is a country that has implemented a WHO-recommended survey looking at drug resistance in recently diagnosed infants under the age of 18 months, all of whom are antiretroviral therapy naive. And in this one particular case, in this one survey, one infant was identified with an R263K mutation, and indeed Sanjana mentioned that mutation as an integrase inhibitor mutation. And we believe that this resistance was actually transmitted because the infant also had the K103N mutation, which is an NNRTI drug resistance associated mutation, and the mother of the infant was on TLD, or tenofovir, lamivudine, and dolutegravir, and indeed the infant had not received any NNRTI containing perinatal prophylaxis. So proof of concept that indeed integrase inhibitor drug resistance can potentially be transmitted to infants, and more data are urgently needed. Shifting gears for a moment, there are, of course, hopes that long-acting dual therapy with cabotegravir and rilpivirine may be a game changer in the treatment of HIV infection, particularly in individuals who experience problems with daily pill taking, stigma, and reminders of their HIV status. So one of the things that Sharon Ann mentioned in the beginning is what's the value of surveillance and how does it inform decision-making? In this slide, I'm sharing with you data also from WHO's report looking at pretreatment drug resistance to rilpivirine. And we can see that the prevalence of rilpivirine resistance amongst adults initiating ART without any prior exposure to ARV drugs ranged somewhere from 0% in Tajikistan in 2016 up to 16.6% in Eswatini also in 2016, suggesting that if there would be a move toward rilpivirine for treatment of HIV, that part and parcel of that would need to be individual level drug resistance testing in order to ensure a fully active regimen. I wanted to spend a couple of moments talking about pre-exposure prophylaxis and associated resistance. So as of July 2023, 150 of 165 reporting countries have adopted WHO PrEP recommendations for prevention of HIV. And I do underscore that concerns around HIV drug resistance must never impede rollout of PrEP. PrEP is highly potent and it greatly reduces the incidence of HIV infection. However, in our report, we do present data from a case series. So In this slide, I'm presenting to you HIV drug resistance reported amongst HIV seroconversions reported in the literature amongst people taking tenofovir and 3TC PrEP. So of the 310 reported seroconversions that occurred and were documented in the literature between 2020 and 2023 in clinical settings, 20% had associated PrEP resistance. And if you look on the right-hand side of the table, you'll note that the prevalence ranges anywhere from 0 in one study in Kenya up to 44% in a study in the United States. And so the weighted average is 20%. There is, of course, likely to be publication and reporting bias, as well as biases related to access of HIV drug resistance testing. And so while the 20% may sound high, due to the potency of PrEP, the absolute number of individuals who are infected with HIV is extraordinarily low, and also those overall with detectable tenofovir or tenofovir 3TC drug resistance is also extremely low. And I reiterate that any concern around drug resistance should never be impeding PrEP rollout. Long-acting cabotegravir has recently been introduced also as a preventative tool for HIV infection. Data are limited, and the only available data to date come from HTPN 083. So as of August of last year, integrase inhibitor resistance was observed in 10 of 16 cases, or 10 of 16 individuals testing positive for HIV with recent CAB-LA exposure. And it's important to note that in all 10 of these cases, cross-resistance to dolutegravir was predicted based on the pattern of integrase inhibitor resistance-associated mutations. But really, additional studies are greatly needed not only to assess the prevalence of potential cabotegravir resistance in individuals receiving CAB-LA for PrEP, but also studies are needed to understand the clinical response to integrase-associated ART amongst individuals who acquire HIV infection in the setting of CAB-LA PrEP. One of the things that I thought would be interesting to share is around global survey implementation. And so this slide shows country survey implementation of acquired HIV drug resistance from the period 2019 through 2023. So the map is looking only at adults, but on the top left, I've included a table of surveys that are either completed, ongoing, or planned for adults and children looking at acquired dolutegravir resistance. And while global data are currently limited, you'll note that there are 24 surveys in adults that are planned and 14 in children and adolescents that are planned. And so hopefully over the next couple of years, we will have more data to optimize our understanding of dolutegravir resistance and global implications. Now, we really need to think about overall prevention of drug resistance. And there are a number of factors that can be associated with drug resistance. There's viral factors that could be pre-existing resistance. There's drug factors such as potency. But there are a number of factors that actually we, as clinicians, we as community members, civil society members, have some control over. And those are patient and clinic factors as well as national HIV program factors. So really, to preserve the long-term efficacy and durability of dolutegravir, we need to monitor for possible gaps in HIV care and treatment service delivery that may be associated with viral load suppression or non-suppression and possible HIV drug resistance. So as part of recommendations, WHO does suggest that countries and clinics routinely monitor ART program factors that are quality of care indicators associated with viral load suppression, remember HIV drug resistance prevention, and or HIV drug resistance. So in this table, I'm showing countries with a high burden of HIV infection that have either met targets or not met targets for HIV drug resistance prevention between the period 2017 and 2022. And I realize the table is very small, but what we're looking at is viral load testing coverage, viral load suppression, ARV drug stockouts, as well as the proportion of people receiving second line, which is a surrogate marker for how well clinics and ART programs act on data in individuals demonstrating viral non-suppression. Now, each of these indicators is associated with targets, and those targets are associated with color codes. Green, excellent performance; amber, average performance; red, signaling suboptimal performance. And so one of the major take-home messages you see is there is a fair amount of red, although there's a fair amount of green. And this is where we can work together with our community partners to really advocate for viral load testing coverage, making sure that viral load test results are used to inform individual clinical decision-making, advocate for the prevention of ARV drug stockouts as well, all of which are critical to supporting patient and population level adherence. So to begin conclusions, the overall prevalence of viral failure with selected integrase inhibitor drug resistance in people on first-line DTG regimens is very low and reinforces the decision to switch from NNRTI-based to DTG-based first-line therapy. Overall, the low prevalence of DTG resistance also suggests that non-adherence is the primary cause of treatment failure. There are some risk factors associated with acquired DTG resistance that can include background NRTI resistance. I didn't share with you, but unfortunately, children or pediatric populations often have higher levels of resistance, either due to background resistance and/or challenges around adherence or ARV drug availability and formulations. PrEP is highly effective, and resistance concerns should not deter the uptake of PrEP. More data from standardized surveys of acquired drug resistance are truly needed, not only amongst populations receiving ART, but also amongst ARV drug-naive infants and PrEP users testing positive for HIV. These surveys help to inform national global guidelines regarding first and second line regimens. And there are finally a number of areas of research that include optimal adherence measures and how to optimize adherence to antiretroviral therapy. Further work needs to be done on the identification of determinants of the selection of DTG-resistant virus in well-described real-world populations. Genotypic clinical correlations with respect to viral resuppression and acquired drug resistance is extremely important. We have some data from the ADVANCE study, which is a clinical trial, as well as other limited country data that suggests that individuals with some integrase inhibitor associated resistance mutations will actually resuppress with optimal adherence. And so we need to really understand which mutations those are and what the phenotype of the patient is that will successfully go on to achieve viral suppression despite having some detectable DTG-associated resistance. We also need to understand how and when to transition people in whom DTG-containing regimens have failed. And finally, we need to further understand these resuppression rates and durability of resuppression in populations taking TLD with and without associated drug resistance mutations. And to conclude, I'd like to thank Amalia Giron and Setan Zale, who work with me at WHO and are also consultants, and also the report contributors listed at the bottom of the slide. So thank you very much for the invitation to present today.
Wow, Michael, thank you so much. And I think you have another presentation to do just in terms of answering all of the questions that have come in. And I know some of my colleagues who have joined, they want a version of this webinar for their region and Southeast Asia, both with data unique to that, more friendly time zones. And I have to say, if anyone out there wants to provide French translation simultaneous, that would be fantastic. We don't have the capacity for that, but obviously Francophone speaking areas, especially those in West and Central Africa, should not be left out. So Um, Michael, there are a lot of questions in the chat. I'm going to ask that you and Sanjana address those that are easy to address in writing, but otherwise, let's take the opportunity after we hear from our next speaker to come back to you and you can unpack them more fully. And also, I want to invite those that are joining with questions that you want to say and not just type, you know, because then you can also share your point of views, your perspectives. It doesn't have to be only in the form of questions. So, a quick plug before I hand it over to Patricia, which is about marrying, as Michael said, this information that is about quality of care with HIV drug resistance, both in terms of prevention and also addressing. So, a few resources that I hope people will find helpful. The O'Neill Institute, UNAIDS, and GMP Plus have a project called the HIV Policy Lab. There, we track 33 policies across 194 countries. So you can see the state of policies in the region, in your country, etc. You can also see the correlation with those policies and some of the key HIV outcomes, if any. We have also built out a dashboard that is looking specifically at advanced HIV disease with our partners at Drugs for Neglected Diseases Initiative. So at advancedhiv.org, we drill down to some of the policies and guidelines that should be in place as part of WHO's recommended package of care to prevent, detect, and treat advanced HIV. Finally, we will put in the chat the links to our previous webinars in this series on advanced HIV. But now, let me go hand over to my colleague, Patricia. Patricia Acero is the team leader at Dandora Community AIDS Support Association, DACASA. She has more than 32 years of experience in the HIV response and access to treatment, access to diagnostics, and access to sexual and reproductive health services and the realization of human rights. So, Patricia, over to you, please.
Thank you so much, Sharon. Based on what my two colleagues have spoken about from the WHO, it's vital that I bring it to the communities and the professionals in the Zoom call. The part that the communities have been able to play in terms of prevention of drug resistance. One has been to push to have optimization of treatment across boards for children as well as adults. For many years, when NRTIs were not being used in the West, they are still being used in Africa. And I can say without fear of anything that we still have people on NRTIs in Kenya. And I've seen what has been said that the issues around, there's also almost 70 to 90% resistance that has been documented. Yet, these are the drugs that are being used in our countries. So meaning that issues of what Sharon is talking about, the quality of care that we are receiving is minimal. I think it's because of where we live. Secondly, we've done advocacy targeting our governments to make sure that they go hand in hand with the policies that are coming out of WHO. That, for example, the treatment of advanced HIV disease that is recommended by WHO is adopted into our policies and used. So for that to happen, we carry out advocacy because we are quite a number of us, especially in the in fact, who are doing that advocacy to have the WHO recommended treatment for advanced HIV disease in our different guidelines. So once that is in, the other prong of our advocacy is geared towards our community. Is the sensitization of our communities on why adherence is vital at different levels. One level is the treatment literacy that Sanjina has just taken us through very well about the HIV virus, about why it's important to take treatment, about why adherence is vital, and issues around you, it equals you. That is another arm of advocacy that we carry out for our communities to be able to make sure that we prevent drug resistance by making sure that our communities understand and adhere to treatment. The other arm is of advocacy is advocacy towards having advocacy at GF processes and also at the COP process to make sure that once our governments have been able to put in place the recommendation of WHO, then those tools that we are talking about, like the tools for CD4 that we used to have initially and that we stopped using once we started using viral load, are brought up and are up to speed. Because currently our clinicians cannot be able to stage the way initially when I started treatment in the 2000s, clinicians were able to stage 1, stage 2, stage 3, and stage 4. But given things the way they are now, most of the clinicians are not able to do the staging. But we are also told from professional view that even when they are able to do staging, they'll still be able to miss those with advanced HIV disease by 50%. So we are advocating for the tools for CD4 within our countries and globally, and also through the different platforms that we have, WHO and also UNAIDS, to amplify the fact that it's quite vital to have the tools in our countries to prevent the unnecessary death. As we started this forum, Sharon talked about the 600,000 people living with HIV who are dying from advanced HIV disease. So for us to be able to stop that, we need the tools in our countries. We know that they are available, but there are processes that are making those tools not to be able in our countries. So our other advocacy is basically targeting our governments to make sure that they're able to bring in the tools that are necessary to be able to diagnose and to put people on treatment. The other thing that we are also fighting for is to make sure that our clinicians, some of them are retrained to be able to make diagnosis for those ones who are already sick with advanced HIV disease, so that they can be able to get treatment on time, the best treatment that is there possible. So those are the specific areas in terms of policy and in terms of the work we do in country to create demand, but also to advocate to make sure that the tools are available. So back to you, Sharon.
Patricia, thank you for that so much. And I just want to flag that Patricia in Kenya is the civil society focal point on the Advanced HIV Working Group. There are others on this call from the Fight AIDS Coalition that have worked with clinicians, they've worked with governments to both form those working groups when they weren't in place, join those working groups, and also influence those working groups, including through the processes that Patricia described. So the Global Fund and getting on those drafting teams, meeting with those CCMs to make sure that the package of care for advanced HIV, as well as what you're hearing about HIV drug resistance, are included. Patricia also mentioned the COP. That is not a COP. It is the country operational plan for PEPFAR, which, like a Global Fund application, request for proposal, funding request, there is where you lay out what is happening in your country, what needs to be happening in the country in an effort to seek funding for it. And as we know, where there is funding, there is a way. So in terms of encouragement for government to adopt, update, and implement guidelines for HIV DR and advanced HIV, those are two good mechanisms to use, in addition to the Advanced HIV Working Group. Okay, that was also me stalling in the hope that Sanjana and Michael and Patricia, you got to read some more of these questions. Some of the questions I'm going to put to you myself. Some of the more technical ones I'm going to ask that you address in writing, and then I will look for more. There are a lot of questions, as I'm sure you've seen, about the causes and drivers of HIV drug resistance. Michael, can you please unpack this for us a little bit more in terms of what do we know? What do we not know in terms of the drivers of HIV drug resistance linked to adherence, linked to incidence of treatment versus incidence of treatment interruption? Obviously, you brought up drug stockouts as an external driver of treatment stoppage and interruption, the lack of continuity there that could develop into help develop HIV drug resistance. And also, Michael, for the folks on the webinar, when we talk about adherence, what do we mean? Taking the medicines at the right time, the right medicines every day. But how much, right? We have a question that is, what does optimal adherence look like? And then how forgiving can that be? Over to you, Michael. Some complex questions.
You've asked a lot of questions. So maybe I'll start off with a little bit of a basic science answer, speaking to what Sanjana said around resistance. And so the first thing to sort of note is that HIV is what we call a viral quasi-species. So in anyone who is infected, there's actually a lot of viral diversity. And we have, billions of viral particles that are created every day. And as we heard, HIV replication is error prone. And so what that means is that somewhere amongst these billions of particles of virus that are generated in a person who is not on treatment in any given day, by simple mathematics and probability, there's a possibility that there could be even a drug-resistant virus that emerges. And that's actually why we call it selection of resistance, because that resistance is actually already there in that viral quasi-species. It doesn't necessarily develop. But because it's at such a tiny level, when we take therapy, we're actually suppressing viral load. And when we have viral load suppression, we have no replication, we have no drug resistance. And that's one of the most important points to keep in mind, is that viral suppression in an individual, undetectable viral load, means no replication, means no resistance. And so that links to what is optimal adherence. And it's a very complex question. The data have been better worked out for the NNRTI drug class than for integrase inhibitor-based therapy. There are some studies related to integrase inhibitor therapy that suggest that perhaps integrase inhibitors are more forgiving, in quotes. In other words, because of their higher genetic barrier to resistance, that higher or lower likelihood of selecting for resistance, should it be there, that adherence could be optimal somewhere between 80 and 90%. Now, that said, I think in reality, it's very hard to judge what is 80 and 90%. And as I responded in the chat, really optimal adherence should be the way the pill is designed to be taken. And so if it's a once daily regimen, the pill should be taken once daily. And that would really be optimal adherence in terms of maximizing viral suppression as well as preventing resistance. And one of the reasons to be adherent is not only to prevent resistance, okay, even if you can be a little forgiving in preventing resistance, but it's really to maintain undetectable viral loads, because for that individual patient, you are maintaining their immune system, you're preventing progression to advanced disease, AIDS, and opportunistic infections, and you're also preventing the likelihood of transmission. because we know that people with undetectable virus are not able to transmit virus to others. So there's plenty of reasons beyond drug resistance to really be taking pills as prescribed. And so in the current era of TLD, it's a once daily regimen. And so I would define that as really optimal. I hope I answered your question. There were several in it, so hopefully that.
Yes, thank you, Michael, so much for that. Can we talk about timeline? There were a few questions. And, you know, when some of us learned about the interplay between virus and CD4 with the immune system, it was helpful in the way, Sanjana, that you described, both to see the disease progression, but also it would be helpful to talk about time in between, right? So, what do we know, if anything, in terms of, and Michael, thank you for the note in terms of resistance, selection of resistance. What does that look like across a time horizon? So, for example, starting with a treatment interruption caused by a drug stockout that, let's say, lasts for 2 weeks. What are some possible scenarios in terms of time? Is it too much of a black box? Do we know anything?
It's yes, well, it's a little bit tricky to explain, but starting and stopping at a high level, the start and stop of treatment could be associated with selection of resistance. Now, because dolutegravir-based therapy is more forgiving, in quotes, at least in theory, if you have that stop, you're less likely to select for drug-resistant virus. You will have wild-type virus emerge and replicate, and then when you reinitiate treatment, you will re-suppress your virus. You know, there's always a risk of potential selection of resistance, but it certainly is far lower than it was for NNRTIs. And in part, that has to do not only with dolutegravir, but the pharmacokinetics of tenofovir and lamivudine that is co-formulated with dolutegravir as TLD, which is the recommended regimen and widely used regimen. So I think we need more data to really answer that question. It's been very well characterized for NNRTIs, but much less well characterized for dolutegravir, in part because emergence of dolutegravir resistance is very rare overall. So it is a good thing, but it makes it more challenging for us to study.
Understood. And perhaps I also shouldn't have used the example of a 2 week stoppage because that makes it a little bit more complicated. But one thing that we have learned over time, you know, we used to obviously talk about the HIV care continuum, as a cascade in terms of when we lose people to care, we lose people to follow up. Now we're learning that, and have learned over the past 10 years, that people will re-enter care. So when that happens, Michael, let's say if someone has been out of care for more than 6 months, that is supposed to trigger, when they re-enter care, that enhanced package that you mentioned. That should include CD4 and CD. That's one of the tests that and medical tools that we've been tracking, whether countries' guidelines line up with WHO recommendations. Other than CD4, tell us what should be happening.
Well, I think really understanding the reasons for patients coming in and out of care is very important. When we look at global data, in fact, there was a study that was published last year that suggested that around 40% or up to 40%, it depends on the country and scenario, but up to 40% of patients may be coming in and out of care. And so that's a lost opportunity for viral suppression. It's a lost opportunity really for preventing new incident HIV cases because of transmission. And I think understanding the determinants of this population churn are going to be incredibly important. So when those individual patients come back, I think it's not only understanding the patient factors, but really looking carefully at program determinants. What is it about the program that may be leading to churn? So a classic example that has come up in many countries and the literature is only being able to get your ART at one specific clinic. And let's say you are a migrant worker and you travel for 3 or 4 months a year to a different part of your country or a neighboring country, that could be a treatment interruption, for example, if you're not able to get your care at another clinic. So, working to decrease barriers of access to care and sort of drug continuity are really quite important at the program level. And there's a whole host of patient factors as well, transport costs that may be associated with HIV care and treatment that may be hidden. Maybe your ART is free, but you need to take a day off work. You need to go out and pay for transport in order to get to the nearest clinic. Perhaps a blood test that you need may or may not be provided free of charge. So these are things that often come up as barriers. Many of the solutions to this really need to be community and driven and community informed, because it's very likely that the determinants from place to place within a country are going to be different, within communities and countries could be different. And so working with communities to really develop locally appropriate and sustainable solutions, and giving tools to community members to develop it, I think is also critical. And I think we're at that stage where we are beginning to do that and certainly need to take that on much more.
Yes, and there is a fear that some of those components of person-centered care that you mentioned that has also fallen under the umbrella of differentiated service delivery, such as multi-month refills, such as community-based ART dispensing, can fall off as under the sustainability and the mainstreaming as part of primary healthcare. Some of those lessons came from NCD management, right, in terms of chronic care management. So I think there is more opportunities for cross learning there as well. I'd like to open it up, and you panelists have the impossible job of typing responses to questions while also listening to new ones, which really is impossible. But I promise we're going to give you some time, especially to answer some of the more technical questions that are in the chat. I'm sorry, that are in the Q&A box. So we have 3 hands raised. Omar, Sarif, let's turn to you, and can you introduce yourself other than being my dear colleague? Over to you, Omar.
Thanks, Saranan. Hi, everyone. My name is Omar Sharif. I'm currently working with GNP Plus, but also working together with Patricia, Saranan, and others under the flag of Fight AIDS Coalition. A quick reflection and probably a question to all the speakers. In my very limited knowledge around HIV drug resistance, I'm aware that one of the response that WHO and also other member states are doing is through national HIV surveillance activities. Obviously, from patient perspective, this is not enough, this is not effective, and creating a loss to the patient because there's a possible risk of late detection of resistant cases and so on. So my question is really to have a better idea in terms of the cost on setting up a HIV drug resistance test as part of HIV continuum of care. How complicated it is to set up such services at country level, and do you have any idea on how much will it cost to set up such services? For us advocate, this is really something that we feel important for us to understand better. as we really see the importance of having such service in place, integrated in HIV care and treatment services. So even though, I mean, I personally experienced drug resistance from NNRTI way a long time ago, and I managed to, to navigate around out outside of the system, meaning, out of pocket money, which is like, something that I don't think is something that we should continue doing. So again, my question is, how feasible is it to set up a drug resistance test as part of the care and treatment package at country level? Thank you.
Thank you, Omar. Can you walk us through what the diagnostic landscape looks like, as well as is there anything promising in the pipeline, particularly for point of care?
Is that addressed to me?
Yes, you couldn't tell, but I was making eye contact with you. Thanks, Michael.
Sure, thank you for that question. So historically, doing drug resistance testing has been very challenging. It requires not only sophisticated equipment, but a lot of human capacity related to virology, particularly retrovirology. And the actual doing of the PCR test itself is not as challenging as actually the data analysis, data manipulation, and interpretation side. There have been, I think, technological advances, and perhaps one of the silver linings of the COVID pandemic has been that many countries have obtained or built capacity for next generation sequencing. And one of the advantages of next generation sequencing is potentially bringing down the cost of a drug resistance test. So generally, drug resistance tests that are done either using available kits, which have become limited for a number of reasons, and I can expand on that in a moment, or through open source reagents, generally those tests are running somewhere between $250, even $300. So next generation sequencing, because of high throughput, can actually decrease the cost substantially. There are some commercial kits, one of which is already available, that is bringing down the price, but it's still quite high, probably in the range of $100 or more for an individual test. At WHO last year, we published a target product profile, which was meant to push the technology envelope related to development of HIV drug resistance tests. We set both minimal and optimal pricing and other criteria. And then one of the challenges for public health programs or ART programs really is about the cost benefit and cost effectiveness of a drug resistance test. And at this point, drug resistance tests often cost more than the next line regimen for a patient for an entire year. And therefore, I think it's really one of the challenges for ART programs in scaling up HIV drug resistance testing to large scale. Particularly so, I think, in the dolutegravir era, when we see high levels of resuppression, even amongst patients with some DTG-associated resistance, until we really understand the determinants behind that and are able to really know which patients may or may not benefit from a drug resistance test, it may be hard to implement at wide scale. But I am aware that drug resistance testing is starting to be done more and more, both for surveillance as well as for individual patient management. And what will become increasingly important and where there needs to be advocacy around is for the quality of that test, because this test is going to be used to make individual patient decisions or population decisions in the case of surveillance. And it's critical that the test be done correctly, and that human capacity be built such that there's confidence in that test result. And just one final, thing about that is we really also need to push for scale up of viral load testing. Some countries still don't have high levels of viral load testing. Everyone should be getting at least one viral load test a year. And if there isn't viral suppression, they need a repeat test. And if that's not happening, that really also needs to be our focus first and foremost, because that is drug resistance prevention, that achievement of viral suppression.
Michael, about diagnostics, and this helps to answer some of the other questions in the chat, including whether there's a recommendation for HIV/DR baseline testing, which I think that has been asked and answered. So the Fight AIDS Coalition, we had a call with Thermo Fisher at the end of last year regarding one of their products. Their test was priced at $140 in the US. There's an Abbott test that is out there called VirusSeq, I believe. In any case, is it going to look better than waiting for NGS to be more ubiquitous and affordable with some of these commercial products that are available now?
Right. So that's a good question. It really does depend on price. And that $120, I think, is the ideal price, perhaps even lower. I know that some companies, including Thermo Fisher, are trying to decrease the price well below that $120 mark. One challenge has been around markups due to importation, and distributors, third-party distributors, increasing price, and I know that companies are working toward that. But just to clarify, there really isn't a role at all for baseline drug resistance testing, or it would be very unusual for there to be at a population level.
No, absolutely understood. So in terms of the one-on-one testing, so Thermo Fisher, I gave the price that they had contributed parts to. It was owned by Abbott, $140 in the US. They want to set the price for their test at $20 for low-income countries. And there's a comment from Maka from Aram, thank you for being on. There is a new test that is currently registered only for research that costs $25 a test, not point of care, but can be used in a local lab. So thank you for that. I wonder, we do have some people from Unitaid on the line. So Pamela, I don't know if you want to come on and say whether Unitaid is working on a product landscape that, have been so helpful in the past, both in terms of figuring out what we have, as well as informing research and development to address what is missing. Of course, I've probably taken the moment where you're checking an email from me, because I'm likely to have many into you at the same time. Okay, but to flag as a need, unless, Michael, do you know anything about the diagnostic landscape, specifically HIV/DR?
Well, there are a number of companies and researchers that are working to develop near point of care or potential point of care type point mutation assays. They're in various stages of development. All of them are trying to decrease the cost as much as possible. Just one word on NGS. NGS does have the potential to be much less expensive, but only if that testing is done in bulk. then that's where you realize the cost savings. If you're doing only one test or a very small number of tests, it actually can be extremely expensive. So there
Right.
are a number of companies that are working on it. And I am aware of other kit-based assays that can be used both for NGS or for Sanger sequencing that probably will be coming available. But I will say from the WHO standpoint, at present, we do not recommend drug resistance testing widely. There really isn't a clinical need for that at this juncture, and really more information and more data are required.
Just taking a lesson from when we were first advocating for viral load, I hope that there's exploration going on in terms of whether pooling can be brought to bear in order to at least flag among clusters that there is a problem in terms of, you know, some of the implementation research and some of the technology. We have another question from Omar that is, and Michael, this goes very closely to what you just said about testing, but any changes that WHO would like to see or consider from the current HIV treatment guidelines for test and treat approach, including same day initiation?
I'm not sure I fully understand the question.
So likely Omar is doing one or two things. He is asking whether test and treat, which should still be in place, but I think Omar is also getting at same day initiation, or do we need to look closer at treatment support in order to help people adhere to treatment? And also, of course, as you say, improve those
Yeah.
adherence enablers.
Yeah, well, we
call them.
need to do everything really at once. I mean, test and treat is extremely powerful, but we, collectively need to understand barriers to treatment adherence and work to really support optimal adherence. But if we are to achieve the 95-95 goals, global elimination goals of HIV by 2030, really testing and treating is the only way to achieve that goal, because it's about maximizing viral suppression, which drives down incident cases. And really now we have the golden opportunity to do it. I mean, DTG as a component of first-line regimens is really a game changer with respect to its potency in terms of achieving rapid and durable viral load suppression, and frankly, very little drug resistance. Despite what we've seen at a population level, it's extremely low.
Wonderful. Thank you so much. I just want to share that Pamela from Unitaid did share in the Q&A box that Unitaid is indeed undertaking a landscaping exercise to determine what tools are out there for resistance testing, adherence testing, and other barriers to introduction and use of these at scale. Sorry. So thank you so much, Pamela. If you have any timeline, if you could also put that into the chat or the Q&A, we would be very grateful for that. We have 10 minutes to go, and I just want to provide an opportunity to come back for sweeping comments, or if you have anything to add in light of this conversation. Sanjana, let's start with you.
Thanks, Sharon. I think, I think we've mentioned a lot of things that we can do to stop HIV drug resistance. So that can include making sure that optimal treatment regimens are available, increasing access to viral load testing. So those are some of the strategies I would say are important in the coming years to make sure that we really combat the threat of drug resistance.
Thank you, Sanjana. Michael, anything? We've exhausted you, I know.
No, I don't have anything to add to that.
Well, let me ask you a question, Michael. it must be difficult for WHO to do two things: to hold in one hand concerning data that, doesn't mean it's scary. It doesn't mean anything should stop in terms of prep, as you say, test and treat, same day initiation, scaling up more and more ART in order to achieve 95, 95, 95. But at the same time, how do you get enough attention to what is an issue in this rather fickle HIV world of ours that always likes a bright, shiny new thing that will only address something really if we use the word crisis around it? So, if you if you want to tell us what a day in your life is
Well,
like
I think
working
it's
in.
about raising awareness with our community partners. We have within WHO what we call WHO HIV ResNet, which is really open to anyone, but it's people who are interested in drug resistance, people who are willing to advocate and support treatment optimization through the lens of drug resistance. But yes, you're right. I mean, I think, but what we need to keep in mind is that while we're seeing some emergence of resistance, it's far, far less than before. And so it's actually really gratifying to see that because it's much less than we saw in the NNRTI era. So it's actually a relief because I can see these 95, 95, 95 goals in sight. And I do think that they are attainable. We just need to keep up with diagnosis and treatment and maximizing viral suppression. So I actually see it as quite positive.
Okay, I see it as quite positive too, and frankly, an affirmation of what many people on this call fought for against resistance to it, which is putting our best drugs first. Hit early, hit hard, rather than giving in to those who were concerned about HIV drug resistance and wanting to reserve the integrase inhibitors for second line. So, bravo to all of those on the phone that did that. Patricia, can we come to you for closing remarks?
Can you hear me?
Yes. You went on mute and your camera's off. Okay,
Oh,
now you're okay. You're all back on. Please go ahead.
am I on now?
Yes, you are.
I would say that drug-resistant testing would be able to improve the quality of patient outcome based on what we know now and what we've seen. As Omar had shared earlier, that he was one of the people who had drug resistance from NRTIs. We also saw that. The cost issue is also something that I saw personally. I hear now that it's down to $100, but that is still more. The time I went for it when my daughter was quite sick in a private facility in Kenya, it was around $400. So just want to see that those barriers around cost are brought down so that patients can be able to enjoy that as one of the tests. So mine would be viral suppression, viral load testing, and drug-resistant testing. These are things that should be made available for communities. Back to you, Sharana.
Indeed, and thank you for sharing your family's experience, and thank you, Omar, for sharing your personal experience as well. I just want to say one thing. When we talk about 95, 95, 95, UNAIDS created that, and we know the earlier iteration of 90, 90, 90. And the 95% is meant to apply to people who started ART. And that's meant to apply to the 95% of people who know their status and tested positive. But in terms of to really find and hold the line on quality and to get an accurate read on the effort to reach and sustain undetectable level of virus for as many people as possible, as quickly as possible, I suggest that as civil society, academics, clinicians, global health actors, and WHO, that we start also defining how are we doing and the gap in terms of the numerator, that is the number of people with undetectable level of virus who are living with HIV this year, since we know that people come in and out. It can't be that once you have reached it and then you fall back. So this year, the denominator should be the estimated number of people living in the country, in the world with HIV. That is the real metric in terms of how are we doing and reaching people and making sure that treatment is effective, affordable, and can fit within their lives. I want to thank everyone for joining. So here's to reaching a higher percentage of undetectable across the world among people living with HIV. Thank you so much to my panelists, Michael, Patricia, Sanjana, as well as the team at the O'Neill Institute for organizing this, and for you all, including the friends that I see and the participants and the longtime activists, James, Edna. Thank you for all of your work, Omar. And I'm sorry I don't know everyone, but I just wanted to recognize you all. So thank you again, and look out for the next series, the next webinar in our series on advanced HIV disease, which we will do a deeper dive into advanced HIV, including CD4. So thank you so much. Thank you, Michael. Thank you, Patricia. Thanks, Sanjana. Bye-bye.